Mike asked, so Mike is a good guy.
Does he get extra?
All right, good morning. So my case is just a interesting type of, I don't know, I was going to try to make it like a simulation type thing because it was like real time for me trying to go through this case. But I'll just present it and then we'll do a differential and then we'll talk about what I eventually found it to be. But just bear in mind when this is real time, it's harder to think clearly. So things seem easier now probably when you review it, but during the case it was not. This was, where's the mic? A proposed cabbage. 73-year-old female comes from home, history of asthma. For the last few months, she's been short of breath, so her family and doctor were not certain, is this her history of asthma or is she having something else going on? She had further workup which revealed she had cardiac disease. She actually had a catheterization with some left main stenosis. They evaluated her functional flow via cardiac cath to see if she would benefit from any angioplasty, stenting, or bypass, and they determined she requires bypass surgery, but just because she was having significant multi-vessel disease. Of note, and this is something I evaluated on her actually at the end of my interview in the pre-op setting. I was talking to her, she was extremely nervous, and I've always noticed people who are very nervous always worry me later on for the anesthesia. I'm not sure my weight, but she was profoundly nervous. I don't usually give patients Versed unless they're very young or extremely nervous, and especially for heart surgery, I give the Versed in the room. I don't want any medicines to confuse my hemodynamics while I'm doing arterial line and all that awake. But we gave her 2 of Versed. She came back to the operating room. She did say, though, before I left her to go set up a room, that I was in an emergency room last week with shortness of breath. They thought it's my asthma. They gave me Ventolin or albuterol inhaler to use and said it may be a bronchitis, and they gave her, I believe, azithromycin, that's the 5-day Z-Pack. So something she threw in there at the last moment. She's not a smoker, penicillin allergy, history of hypertension and cholesterol. Kind of obese also, elevated BMI, and not the best looking airway. Pre-op echo, I think it's got cut off here. Systolic function is good, 55-65%. Some diastolic dysfunction, as we expect with somebody with long-standing hypertension. She's got multi-vessel disease, but she's coming from home. She's not short of breath that day. She's not having fevers or chills. Brought her into the operating room, had already given her 2 of Versed pre-op. We gave her another 2 of Versed while I'm doing the arterial line. And I approach patients differently. A lot of people here don't do this, but I don't like to ventilate patients that I feel may be a struggling airway for me. I don't have the world's biggest hands to ventilate, so I rapid sequence these guys. I've seen a lot of patients that struggle if I try to do with rocuronium, so I did rapid sequence. She was not an easy airway, but I was still able to direct laryngoscopy, intubate her with a Miller 2. Had no other issues. I mean, I generally keep it pretty clean when I induce. I usually give fentanyl. I'm not sure why I did not here. So she only got lidocaine, succinylcholine, propofol, and the Versed. This is all she got. She got no antibiotics pre-op, nothing else to cause any other issues. And so easy intubation, bilateral breath sounds. Started on our cardiac inhalational that we use, isoflurane, and then I gave her rocuronium for her muscle relaxation. So here, generally the way we do it, our cardiac patients, so now their arterial line's already in, they're awake, now they're put to sleep, airway is established, then we start getting prepped to put in our central line, our swan, she had very short thyromental space, very thick neck, not the easiest looking neck. I always use ultrasound for central line access regardless, but this one was not the easiest one. It was still one single stick, but she was very thick neck, and the dilation of the skin, the vessel was more than usual. I really had to make bigger cuts and try to dilate. I almost bent the cordis catheter and the wire. She was that thick and difficult to access. But got it nonetheless. There was no second stick. There was no concern about that being an issue. Let me skip this part first. So as soon as I got the cordis in, it's sutured now. We're getting ready to do the swan. So you're double gloving and everything. I noticed the machine is alarming. And I thought I disconnected the circuit. Sometimes when we turn the head to do the central line, I thought I disconnected the circuit. I'm like, why is the end tidal drop from 40 to 36 to 7? I mean, profound. And I'm thinking the ventilator may be disconnected, ventilator may be malfunctioning. So I had to break scrub and thinking, is she bucking, is she biting? Her peripheral IV that we gave, the rocuronium, obviously the succinylcholine IV worked because the succinylcholine made her fasciculate, we got her asleep, but then the nurse had to give the rocuronium and was saying the IV wasn't exactly working that well, so she had to manipulate it, but it went in. So I'm thinking, did I cause pneumothorax? What's going on here? Why are we getting profound, significant hemodynamic instability? End tidal is basically nothing, and blood pressure now has significantly reduced. And so to me, the differential is this is a patient with 70% left main. I haven't given her too much induction agent. I'm watching her beat-to-beat variation on the arterial line. So what has been going on here that I'm missing? Any thoughts what you guys would think? I mean, I'm thinking, I'll let you know what I'm thinking the first few minutes, because it's not an easy thing to think when the patient is in front of you desaturating and hemodynamically about to have a cardiac arrest. So I just put the line in, so I'm myself thinking probably I dropped a lung. It's got to be. I mean, usually I don't, but it's fine. Let's evaluate this. So I actually called Lutrin, and his PA came initially. So you can see, this is my arrow.
So was she hypotensive at the same time too?
She was. She started dropping her pressure pretty fast. I have a pointer on this, Mike. You do it?
Her sats were bad, did you say? What are you trying to do?
Sats, I'm trying to show up there, but you can see.
Oh, yeah, you get one.
So you can see, look, end tidal 44, 40, and the third line, 36, and then 7.
And you assured that the tube was in the, did you look?
So I double checked, exactly. First thing I did is unscrubbed, got my laryngoscope, looked, tube is in. Because I thought, wow, maybe I turned her neck, she's been extubated. No, tube is in.
Cuffs up, you're not leaking.
Cuffs up. Second thing I did is I took her off the vent, tried to bag ventilator. Now I'm not really able to move much air, so I'm thinking,
Pneumotension.
yeah, did I cause a pneumotension, the tension pneumothorax?
How about a history of DVT? Was there any history of DVT?
No history that we know of. She's from home. She was sick a week ago, had recent bronchitis, given antibiotics. As far as I could tell, she's moving around, doing stuff, not sitting around, and no history of hypercoagulable state. No reason to have a PE, but that is something that crosses your mind.
Infiltrated IV, and then she's waking up.
So, I mean, but I don't think it would, it could cause her to start fighting. I actually had the nurse give a second dose of rocuronium, because when I wasn't able to ventilate, I'm like, is she fighting me? Is something going on here? She was 95 kilos, so 50 milligrams of rock is not necessarily the full dose, so I just said, go ahead and give a second dose while I'm trying to troubleshoot this. But what I recall very clearly is the ventilator was not able to deliver any breaths. It was the weirdest damn thing is the ventilator broke in. Each time I put her on different modes, pressure control, volume control, anything, ventilator would not drive any kind of pressures. Her peak pressures that I did suction her, peak pressures were 40 to 50. Her end tidal went down to 7. We have cerebral oximeters we place to monitor their flow to adequate flow for their cerebral oxygenation. They were 50 to 60s, came down to 19.
Did you check breath out?
Yeah, there was minimal breath sounds. And so that's why
No wheezing?
there's no breath sounds.
No
There's
breath
no movement at all. So that's why I had Tim as the PA. I had Lutrin. Lutrin was taking his time. I said, Tim, go ahead and put bilateral spinal. I mean, I dropped the lung. It has to be, I can't ventilate. Patient's stats are going down. Literally, her lips were purple.
When you squeeze the bag,
Very hard to ventilate.
did you get any end-tidal CO2 back?
I don't even notice that part, but it was very hard to ventilate. Yeah, so I was profoundly, I don't remember calling anybody for help. I just, so this is the day, this is Monday. Colombo, his last case, had done a midnight dissection. You remember that one, that aortic valve? So Lutrin, everybody was exhausted, and I come in. I was going to relieve Dr. Colombo because he had to go to his surgery center. So I was there early. I saw the patient. I went around it in the ICU. Everything looked like it would be fine, and then I think Lutrin was not findable. Nobody was able to be found. The PA came and said, dude, you got to put in some, I was going to do it, but I was trying to ventilate, so I'm like, just put in bilateral spinal needles. We got decurrent pressure. I believe this is tension pneumo. I put a line in, and I can't ventilate, and I don't have an end tidal. There's nothing else that could be causing this.
Why would you do bilateral?
Well, you don't know what side it is. I did this side, but it could be tension. It could have shifted to this side. You can't tell what side, and when I'm trying to bag her, that I cause the other side to
Oh, I see what you mean.
She has history of asthma. Does she have emphysema? We don't know about. Does she have blebs? You never know. You got to do one side and the other side, and just it made no difference. Tim did both sides. Still made no difference. I think the next, and we went through all this, so it was not an extubation because I reevaluated. Pneumothorax, you would have heard air coming out and immediate improvement of hemodynamics and ventilation. None of that. That was not seen. So you think you get a chest x-ray, all that, but that takes time. Nothing happens that fast. In the meantime, somebody who's morbidly obese and has now been paralyzed, she's going to desaturate in seconds. Ventilator, I took her off the ventilator, so I started ambu bagging, and that's the only thing that gave me maybe 50 cc's to 75 cc's of tidal volume to even maintain her. I'm not sure how else I could have ventilated her. So
how high were your pressures, Kurosh?
for the peak pressures,
Yeah.
45, 50.
To get 50 cc's of tidal line?
Yeah, it was ridiculous. It
Kurosh,
was
the big question is,
the first time I've ever had that happen after, I don't know, 15,000 anesthetics.
was the EMR pulling in your vitals? That's the big question.
It did, and then I corrected some of them. But no, I left the profound ones. You know you can correct them, right, before they.
20 minutes. You have 20 minutes.
That was the first question I asked them years ago. Can you correct it without being shown? They said yes.
In half an
You
hour.
have like half an hour to
Half an
correct
hour.
it. Anyway, but this one I didn't need to correct it because I knew it was catastrophic. So we had no blood pressure. Nurses are very helpful in the cardiac room. So somebody's starting the neo drip. I've evaluated the ventilator. I've taken off the ventilator. Things that we've learned in the ICU is whenever you can't ventilate, people are having issues, just take them off the vent. Because the ventilator was not a help here to me. Is this patient auto-peeping? Are we causing further issues? So I'm just trying to bag ventilate. Really the thing that...
They do a gas for you? They do ABG?
No, I don't think we had time. We were about to do CPR. By the time Lutrin strolls in, it was already almost time for CPR. So anyways, no, he was just not there. It was me and the PA and the nurses, so it was over minutes. You really, something like this one, you can't ventilate, and you've already induced them. She was profoundly unstable, and just going through my mind, I'm thinking, is this a pneumothorax, PE, what else? What else can you guys think we haven't talked about that it could be? And what medications would you be giving at this moment? What's that? Allergic reaction. Epi is the best drug we have. So I took out Epi. I'm like, this has to be something else. Anyways, the blood pressure was tanking. Cerebral oximeter is 19, 18. I mean, there's literally no adequate blood flow to her brain. She's gonna have a cardiac arrest. Actually, I'm thinking to myself, where is Lutrin? Let's start ECMO. Let's start, I mean, we gotta get this patient, we can't have this one go. We haven't even started incision. And I had said, due to her lack of good ventilation, we really did see a significant drop of her cerebral oximeter. What else did I do next?
Now, at what point did you give the epi? You just showed that one thing that you finally were able to ventilate. Was that
Yeah, so
before
let me
or
go
after?
back, I'm sorry, there's, I don't know, the times may be somewhat made up, because obviously I wasn't, but they're pretty close. Like I said, I make some things up, but not really. So, it actually is real. I think somewhere in the, I think around 8 o'clock is when I gave epi. So that's when, you can't see here, but the end tidal goes from 40 to 7. So
it was better.
So remember we said we induced very clean induction. We didn't give ANSEF, didn't give anything that would cause significant allergies. Lidocaine, not usually. Propofol, I looked it up, is not very common. Sux can cause some allergies, and then rocuronium can cause allergies. But the only thing that started to make her improve is the epi. I was thinking of doing epi drip, obviously, by that time, but now I'm giving epi boluses and able to back ventilate. And that's when we eventually are able to actually ventilate. And then I start thinking to myself, it's not an intervene extubation. Now I have an x-ray coming in. They do a bilateral x-ray, minimal pneumo. That's from Tim's neo decompression. There is no tension pneumo. There's nothing. The line is in the right place. So obviously the thought is it's got to be one of the medicines I give. This must be a bronchospastic anaphylactic shock that I'm causing. Because there's nothing else that would explain this. We have methylprednisolone that we give for prophylaxis for pericarditis, so I had that already there. I gave that. Not that that's going to work right away, but I gave that. I gave an H2 blocker, Pepsid. I gave Benadryl, ketamine. I'm thinking, part of the problem is, so you think, wow, if it's bronchospasm, asthma, turn on the SIVO. I couldn't ventilate to even deliver SIVO. That was the issue. The whole time thinking, I mean, if I had this asthmatic person up in the ICU, we would have brought a ventilator with a SIVO floor, and I could not even give the anesthetic inhalation on. So I'm just doing ambu back to just exchange gas. What's that?
Why ketamine?
It's a very good bronchodilator too. Anything that can bronchodilate, I was trying to think of giving. But the thing that worked best was epi. Epi was what really worked. And so the discussion is, as I think Jennifer said it best, is it was anaphylaxis. It was profound anaphylaxis. Which drug do you guys think is causing this? Because I didn't think about it until later.
Rock.
And you saw up there, before I admitted the patient to myself in the ICU, I thought to myself, oops, why don't I give, I'm not sure why it's doing this, why don't I give some Sugamidex? Let me see. So, and I looked up, let me see if I can figure this out.
I thought that you gave the rock after you had the bronchospasm.
You can call that.
You gave an
No,
additional
no,
dose
no,
of
no.
rock, but he gave.
Oh,
I
you
gave the
gave some
additional
upfront,
dose.
too.
Correct.
Can't sucks cause some like major
Sucks
histamine
can.
release?
I looked it up.
Yeah.
Sucks definitely can, but rocuronium is the most widely reported. When I was a resident, we learned that it happens quite a bit. How I lost. Oh, you see it up there. So put the line. So it was the timing was what confused also somebody. Line goes in. Now I can't ventilate. There's an alarming ventilator. So did I cause a pneumo? At that point, also rock has already been given. At that point, I have them give an additional rock because is she bucking? Is she fighting the vent? I mean, we're not going to reverse her. I can't ventilate. I have a tube in. I'm going to give her another dose to get her hopefully more paralyzed. She's 100 kilos, rock 50 milligrams baseline. It's not necessarily always as profound the muscle relax, so I gave her a second dose. Discussions, so what I found in my research is, and there's multiple case studies throughout, everywhere, every country, Japan, Australia, and in fact it looks like rocuronium for a while was almost not approved because of its anaphylaxis properties. So they say incidence of anaphylaxis 1 in 22,000. That's very, very low for patients with atrial cardiomyopathy. Sucks is pretty high, 1 in 2,000. Didn't realize it was that high because you usually don't see it. You see bradycardia or pseudocholinesterase deficiency patients, but not. At least I have not noticed this kind of bronchospasm. Rocuronium is 1 in 2,500. I've given rock multiple times and noticed blotchiness, redness, but but I've never had difficulty with ventilation. In this patient, afterwards, when I saw her in the ICU, she was blotchy and red. So she had skin changes. She's never had anesthetic. I think her previous anesthesia was all either LMA or colonoscopy or something like that. So she never had a anesthetic with muscle relaxation from her history later on. What else did I find in the research? It's all an IgE mediated antibodies. So one of the things I sent off, actually during the time while I was trying to stabilize her, we were sending off blood draws. One of the things we send off is serum tryptase. So that's a good indicator of IgE release anaphylaxis reaction. And days later, it did come back profoundly elevated. It was 25. The laboratory uses less than 10 to be normal. So she was very high. She was actually eventually stabilized on epinephrine and extubated later in the evening in our ICU. Never had surgery, obviously. Later workup at her outpatient in Loyola revealed she did have rocuronium. They do skin testing, allergies to rocuronium. So that's what it turns out to be, but just the timing, it's very hard to evaluate that, think of that real time since the patient's about to crash and burn on you and they already have cardiac disease and they're not the best airway and they have pretty significant sleep apnea. So what I did notice, she did have cutaneous signs, some urticaria developing. Did she have angioedema? I don't think so. I didn't notice that. She did get hypotension, like Connor said. Her heart rate was going up. She was requiring vasoactive support. Did not see any bradycardia, but like I said, she barely was moving. Her chest bronchospasm was setting in, and she really was pre-cardiac respiratory arrest. She really, before the dosing of epi and bag ventilation on the ambu, she was basically about to have a cardiac arrest. The whole time thinking, I mean, it's not like I'm doing a gynae case. Where's the heart surgeon? Can he put me on bypass? But I think he was tired. He worked all night, so he really was not able to assist in that. So we thankfully got her out of this. But the studies show that yes, you do give epinephrine. It's vasoconstrictive, bronchodilation. You're going to improve her cardiac output and just reduce any kind of anaphylactic reaction, reduce releasing any mediators, the IgE. So I was pondering even doing epi drip, but she was starting to then thereafter getting hypertensive and tachycardic, and she was improving her ventilation, so I didn't have to do the epi drip. And as I had mentioned, blood test that we can send off, it's more just for showing yourself what do you think happened, and maybe for the future anesthetic, you can send off something called a serum tryptase. We've had people, we've had cases, people have called us for spinals they've done, and now they don't know if it's the spinal or is it the ANSEP they give. And I believe a lot of times we see it's ANSEP that does it. So antibiotics are very much common to that, and we've sent off serum tryptase levels for those, and those have also come back positive.
That has to be sent in within a half hour. Or
Yeah,
something, right?
we sent it pretty soon. Yeah. Somehow I was thinking of that, maybe just for fun, but I just said, you know what, why don't you send an extra vial for this blood test that we'll probably want for later.
Rob and Jay, do you remember we had a case just like this? It was Chuck Miller patient.
Oh,
It was Victor.
Yeah.
Exactly.
Yeah, but
like
that
it
was
a 38-year-old.
was that anaphylaxis, you think, or?
What she had was, well, you know, it's a healthy girl. She's in room 16, I think.
Yeah, I
and
remember.
they were thinking all of a sudden, things just didn't look right. They weren't getting a pulse oximeter. What she became was profoundly hypotensive, and then she became profoundly bronchospastic.
This one, I wasn't here, but I remember
It was
reviewing
horrible.
this in Colombo. Told me about this. They called him. He could not move the lungs. He could not even squeeze the bag at this point. So there's a point that it becomes so profound. There is nothing you could do. But I mean, we have a heart surgeon. We could have probably done ECMO, but that one, it's either they were saying it may be not good intubation, which I doubt it.
No, they took the tube out, put another,
Correct.
put it in.
They thought it was
It
esophageal.
was a slender young girl,
Yeah.
no problem with intubation.
And they got
Took it
rocked.
out, did it again.
They got rocked, they got probably and stuff. And the other thing is they do that vaginal prep. I'm always watching them on that. There's reports of that significant uptake when they do that betadine vaginal prep of them getting anaphylaxis from that. Now they have them in lithotomy and now they're prepping them. There's case reports of significant catastrophic anaphylaxis from that. So you gotta be watching these patients. You never know. That's so many different variables. This one I knew, I had only given 2 or 3 medicines, had to be either sucks, rock, and nothing else. I don't believe propofol does anything. There was some reports of allergic reactions to it, but not this profound. But I don't know if they didn't give epi fast enough, but once you're in that cycle,
It was, at times, they just thought
bronchospasm,
the
it's-
monitors weren't working, and so I think they missed their window, but the shock to me, and it shouldn't be a shock, but you know, you're busy and you don't read all the literature, was that when we researched this, muscle relaxants are the #1 cause of
number one
anaphylaxis.
cause, yes.
You know, we're always thinking it's at latex or antibiotics, but heck, no, I mean, in all of them, every single one of them cause it.
I mean, you see rocuronium causing blotchiness. You guys have seen it. I've seen it a lot. My own practice, I do. Nobody else does this. I give everyone Pepsid just because of her stomach, but I think it helps with H2 histamine block. I don't give Benadryl, but I mean, at least I give some things to minimize risks of any kind of histamine release or anaphylaxis risk. But we see this all the time. Why this was so profound on her? It's just
So
some people
what
must be more.
made you decide to give the Sugammadex?
Did you give it?
The
or you
Sugammadex?
didn't?
Yeah, when
No,
did you-
so at the end, when my brain was clear, I'm going upstairs to the ICU. I'm thinking I gotta eventually extubate this lady,
Oh,
and
I see.
Oh,
then I thought, wait a minute, we have a drug that reverses. Will this help? So then I looked up studies on this.
yeah.
If this happens to you immediately, because if I didn't have that clear mind to think, as soon as this happened, where's Sugammadex? Maybe this will stop the cycle. Does not necessarily help. There is some reports, some studies that show that you give them together, rocker and Sugammadex complex, you get actually a worse anaphylactic. Sugammadex was approved in Europe 10 years before US. The reason that the US did not approve it is anaphylaxis. People were getting anaphylactic reactions. So you have to be very careful with all these medicines. Nothing, but there is 2 cases that it was in Japan. They gave it probably very rapidly. Maybe they gave the rock, saw it happen in a minute or 2. They gave the Sugammadex and they claimed that the patient completely recovered, circulatory collapse, completely recovered. But then there's other reports that they gave Sugammadex and rock, and now they both had worsening outcomes, and then they did different studies, and they could not, the serum, so they hear that serum tryptase levels were significantly elevated. They thought maybe Sugammadex caused this to be worsening, but they do intradermal testing, and it's not the Sugammadex. They found this one to be the rocuronium, but the complex is a chance of causing this. So you can give Sugammadex maybe earlier on, but it's not guaranteed. The only thing that probably works is epinephrine, and hopefully they break that cycle. So yeah, just thought it would be something we'd give every day. Every day we think about it, and we never. It's a good ABC thing to think. What could be causing this, and what can they do to try to save this patient? Because she was profoundly terrified the next time she came back. So she goes home. She's fine. The next day she's awake and alert. Apparently the cerebral oximeter, I mean, a few minutes of no brain flow doesn't affect people too much, I guess. But she was fine, but she was profoundly scared. So of course I gave it to soda. I just don't want her to see me. I thought she would be very nervous, but she did see me afterwards. I was her ICU doctor. When I discussed with pharmacists, what should we do then? They said try cystatricurium. It's a completely different analog. So actually, Bill used cystatricurium. She did cystatricurium, and she did very well. No issues. But it was all rocuronium, because everything else, all the other drugs, was again used the same medications I use. Same line placement, same everything. So it turns out that she had difficulties with the rocuronium. And then this is the questionnaire I ask every patient: did you die? Yes or no? And that's how I know if I did well. If anyone died, then what's the problem? Because these people die usually. I mean, there's a lot of badness we can have, and we know that. And that lady had a good cardiac system. Our lady had bad coronaries. So she could have had renal failure, stroke, and/or catastrophes.
Okay, this is off subject a little bit, but I saw you use isoflurane.
Yeah.
Why do you guys use that for cardiac
It's
instead of
a
CPAP?
pretty good cardiac. For
It's
cardiac,
standard preconditioning.
for cardiac stability and preconditioning, so they don't.
It has a-
Plus, we're not extubating these people, so it's, you know, I feel it's the cheapest, easiest to use, but there is data about this keeping preconditioning with isoflurane.
The perfusion is also run. But I mean, the salient points are that you're putting somebody to sleep. You're putting somebody to sleep. Are you noticing what is causing this high peak pressures, inability to ventilate? What made it more confusing is it's right after I put the central line. So, did I drop the lung? Did I cause anything else going on? She had this outpatient visit to an urgent center for bronchitis. They put her on Z-Pack. So does she have already an inflamed lungs? Now she comes back 3 days later for heart surgery. Now she's only on albuterol. She's not been really fully worked up for this. So there's things that maybe predispose her to even having higher chance of that reaction. But you know, there's people who have higher risks of they have history of asthma or aspirin allergies, or that Samter's triad. They have sinus infections. They have higher propensity to develop allergic reactions. She seems to be one of those that fit that criteria. But this is all rocuronium. And I was looking up the rocuronium we have. It's a compounded agent. It's not a purely made, those pre-drawn ones are not purely made. When they compound them, not sure if these cause higher risk of reactions or not. But that's the drug I gave her, so that's really what we determined it to be. And she did well with the alternative.
Thank God you were
They die.
This is the question, did you die, yes or no? If no, then you did wrong, right?
You talk about the tryptase?
Yes.
Yeah.
Tryptase was 25, yeah.
No, but you gotta remember, if you think about it, you gotta draw, all right? That's the biggest problem.
It's only.
People
Yeah,
forget to
so-
draw the tryptase.
You know, Molly just had a case where she had an intraoperative, like, you know, hypotension like that, and she sent one, I'm curious, this is a last piece.
Yes, that's a hit.
She's not here, but
Like Bill says, it goes out of the system fast, but it also can cover your butt. Because the family later on, now was the ICU doctor there, what happened? What drug did you give? Everything, as you can see, was profound. We went from an N-tyl-CO2 of 40 to 7. There's no drugs that I've given it to cause that. I didn't give nitroglycerin accidentally. I didn't give anything. It's an allergic reaction, and the rocuronium is really what was the culprit. It's just you have to figure out what it is, and hopefully epinephrine is your savior. That's the single drug that saved her.
I think at the end of the case is how many different drugs were just slamming one right after another. You're giving Zofran, you're giving Toradol, you're giving neostigmine, you're giving glycopyrrolate. You're thinking, wow, what does this do at the cellular level to the body? Boom, 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 boom. Yeah, it can do a lot of harm.
So be careful with rock. Dangerous drug.
I think that was the drug that was considered Chuck Miller case too.
I think so. These are the